Hello, today my presentation is on TAVR with Navitor Vision, valve design, the data, and the latest tips and tricks. Here are my disclosures. So the Abbott Navitor valve has just recently got US FDA approval, has been commercially launched for over a year now. You can see that the valve is a self-expanding intra-annular valve with large cell designs, with large treatment range, has an active sealing cuff to mitigate against paravalvular leak. You can also see that there are three opaque radial markers at the level of the commissures at 3 to 4.5 millimeter depths to guide optimal implantation. The delivery system is very flexible. It's based on 14 to 15 French, depending on the valve size. You can see it's a very ergonomic handle. Essentially, you can do this procedure almost as a single operator. And you can see that has a stability layer to guide tracking and deployment. Now, the large cells for this intra-annular self-expanding valve is rather unique in the sense that coronary access should be no problem after valve deployment. And you can see the French size of each respective cells based on the valve sizes. Here are the dimensions of each valve sizes, the range from 23 to 35 millimeter. And this is very helpful in terms of guiding even potential lifetime management and future redo TAVR. Here's the sizing chart of the Abbott Navitor Vision valve. You can see there are some overlap of the sizing range between the two sizes. And of course, that depending on the native anatomy in terms of whether you need to stay in a lower size versus need to upsize to a larger valve. Now, my colleague Rishi Puri has recently presented at the CRT meeting of the 5-year performance of the Portico valve based on the number of registries and trials. And you can see that the Portico valve is actually different from the Navitor valves, the earlier generation Abbott platform. There's no active NaviSeal. You can see that there. And also the leaflet designs are actually the same. So you can see that here in terms of the difference. Now, Dr. Puri presented over nearly 1,500 cases with 5-year follow-up of this particular cohort of patients from both US, Europe, and Canada, and Australasia. These are all high extreme risk patients. And you can see that at 5 years, the hemodynamic performance is actually excellent. Not only the gradients remaining at less than 10 millimeters mercury, but you can see that EOA is 1.8 centimeters square. Also, you can see that the paravalvular leak over time has improved. You can see that here, despite without any kind of active sealing or cuff to mitigate against PVL. As well, you can see despite being an intra-annular design, the incidence of severe PPM, prosthesis patient miscarriage is extremely low. You can see that here, 5.6% in all patients and actually 4.7% in small annuli. Now, what about structural valve deterioration over 5 years? You can see that with moderate hemodynamic structural valve deterioration, it remained relatively low, both in terms of small and large annuli. You can see that the bioprosthetic valve failure here, in fact, is quite low at 3% over 5 years. And valve reintervention remained very low at 1.8%. Now, how does these Portico Abbott pool data compared to the other trials and registry? You can see that here over 5 years, obviously these are apples to oranges comparison, but you can see that the incidence of moderate structural valve deterioration, valve thrombosis, endocarditis, and bioprosthetic valve failure are all very low and very comparable to the other valve platforms out there. So in summary, you can see that the Abbott first generation Portico valve, despite being a different design with no paravalvular leak mitigation, actually has sustained low mean gradient and also large effective orifice area, and also a gradual decrease in paravalvular leak, with also low incidence of structural valve deterioration and bioprosthetic valve failure, as well as valve reintervention. Here in the United States, the Envision trial and also the Vantage outside US trial will certainly evaluate the Navitor Vision valve in the low and intermediate surgical risk randomized and commercially available valves. So these data will be very important to compare the Navitor Vision platform with the other commercial platforms. Now, I want to spend the rest of the time talking to you about tips and tricks and actually how to deploy the Navitor Vision valve very effectively, efficiently, and reproducibly. So first of all, how do we use these vision markers to target the implant depth? Some of you may have experience already with the Abbott FX platform with the three depth markers, but this is very similar in that design. So what we typically do, we start with the free cusp view you see on the left, and then of course the cusp overlap view, and we deploy the Navitor Vision valve also with the cusp overlap view at the beginning, and you can see how the delivery catheter tracks very easily across the native annulus. Once you're at the annulus, you can see that we typically like to start with the Navitor inflow at the level of the annulus, or just a little bit below. And you can see the vision markers as a flower is highly visible on the cusp overlap view. You can see that we also take the parallax out. The stiff wire placement usually is at the apex, but it's less relevant here with the Navitor platform because typically we don't even need a third operator or an operator holding the stiff wire maintaining in place. The left hand holding the catheter in position, or the operator one, depending on what your setup is. And then the second operator or the same operator can use the right hand to turn the wheel. And you can see how it deploys very easily with only even one person. You can see as the device flowers to 80%, there's absolutely no pacing required here, unlike other valve platforms. And once you go to the mid portion of the delivery catheter, because of the intra-annular design, is already functioning. So there's really very little time for hemodynamic compromise or hemodynamic changes. And once you get to 8%, you'll hear the click on the wheel. That's when you can go to the LAO view to check for assessment of the implant depth on the left cusp. And you can see that here, this is what we call the frame alignment view, because these large cells, you can easily actually align the frames. In this case, you can see the left cusp is 0. So clearly, this is a case where you would need to recapture. And this is really much the same as you were doing, let's say, the Abbott valve, because you would also need to recapture in that instance. And what we typically do, you would recapture in the same view, and you can now see the frame alignment view with the cells completely overlap each other and no parallax. And you can see now the left cusp is certainly a little bit deeper now. You can see also the delivery catheter with the non-cusp a little bit deeper, but this is not a problem because with the Navitor valve, typically as you release, the valve actually pivots a little bit deeper on the left and actually higher on the non. So actually it equilibrates itself. And so the implant depth will not be this deep on release on the non-cusp. And you can certainly see that here after release, this is a cusp overlap view. You can see that here. You can see the depth is roughly around 4 millimeters to 5 millimeters on each side. So in summary, with the Navitor Vision, the depth markers are really helpful during the initial deployment to avoid implanting too high. And you want to start the inflow just below or at level NCC base with the marker at above the annulus and let the valve flowers and kind of descends a little bit. There's no need to push a stiff wire. In fact, you want to pull back the stiff wire away from the apex sometimes to avoid tension in the system. You want to aim 2 of the 3 markers at or below the annular plane at annular contact on cusp overlap view, especially when the inflow has parallax. This is not dissimilar with the Abbott valve when you deploy, based on you can see a lecture that I've also posted on YouTube on the Abbott FX platform. Now, there is a tendency with this particular catheter, given its flexibility, to lean towards the outer curve and miss the left cusp if you flower too quickly or if your stiff wire is too much into the apex. So what you do is when you go to the LAO view to visualize the non-cusp and the left cusp depth, if the left cusp, as you saw earlier, is at 0 millimeters, you definitely need to recapture. And it's very easy to see with the vision markers. We prefer to fully recapture in the LAO view to advance the catheter deeper, then pull back to help center the delivery catheter. And you can see that very well on the LAO view, so the valve will not miss the left cusp again at annular contact. Once you're satisfied with the implant depth, it's really a single operator release, as I mentioned. You pull back the wire, the operator one does not really hold on to the delivery catheter. Definitely no pushing and definitely no pulling. And the operator just slowly release the valve with control pacing if you want to reduce movement on release. Next, I want to tell you about how to optimize the catheter position of the Navitor system to avoid recapture. Again, you can see the free cusp view and the cusp overlap here for this particular case. Now, what you see here is that the valve has crossed the annulus, but we intentionally go a little bit deeper, and then we pull back towards the annulus to be able to center the catheter before we start the deployment. Again, I want to show you this is actually the annulus. And you can see that we start deeper and then pull back just to help center because the flexibility of this delivery catheter. And this avoids the delivery catheter being too much outer curve. So when you flower the Navitor valve, particularly with the larger valve, that it will swing towards the left and miss the left cusp. This is quite important based on our implant experience. Now you can see that here you start lining up with the marker to the NCC base, and you can see it just descends a little bit or barely descends. It's quite stable. And you can see this is the cusp overlap view, and we're aiming for 2 of the 3 dots below the annulus. If you have 2 of the 3 dots off the annulus, you're definitely too high, and you will risk pop out. You definitely will need to recapture. So here's the frame alignment view. You can see that here the large jets overlap each other. There's no parallax on the inflow, and you can see that here the non-cusp is around 4 millimeters. The left cusp is around 2 millimeters. So we feel this is a very good implant depth at 80%. And we choose to release the valve. You can see that here at the aortogram, you can see really a 3 and 3 millimeter depth. So it's really stable on release. Maybe a little bit pivoting if you're a little bit more to the outer curve, but you will not have a pop out if you deploy at this particular depth. We do not recommend aiming for non-cuts at 0 millimeters. So in summary, to avoid recapture the Navitor vision, we visualize the catheter crossing the annulus a little bit deeper, then pull back to optimal starting point to center the catheter across the annulus. You aim 2 of the 3 markers at or below the annulus on cusp overlap view to avoid missing the left cusp. As long as the left cusp is deeper than 0 millimeters, it's okay to release, and you don't need to push or pull the delivery catheter during release because this system is quite tension-free. Now, there's been a lot of questions about, at this iteration of the Navitor Vision platform, how do you perform the tap release? Because that can be a challenging issue. So to visualize the 3rd tap release on the delivery catheter, you need to be patient, number 1. You usually would see 2 taps released already. It's the 3rd tap because there are 3 taps on the Navitor Vision valve that are loaded onto the delivery system. Unlike the Evolut system, which has only 2, you need to be aware that you see the 3rd tap completely separated from the delivery catheter. Now, don't push or pull the catheter while the 3rd tap is still engaged because otherwise you'll risk movement of the valve. You want to make sure the stiff wire is pulled back to avoid any tension in the system. So what you do is you rotate the CM to LAO, RAO, and even sometimes cranial projection to try to visualize the 3rd tap. I would recommend you control pace to avoid any kind of extra systolic beats. And then you rotate the catheter slowly clockwise or counterclockwise to free the 3rd tap. And you actually can see the 3rd tap separate from the delivery catheter before withdrawing slowly. So don't withdraw the catheter until you see it separated. And you also want to ensure the nose cone does not contact the Navitor frame. This is how pop-up can happen with these self-expanding platforms. So here's an example going sequentially how it sees. You can see 2 taps already released. The 3rd tap you cannot see easily. So we go on multiple views. This is LAO view. You have to see the first we start RAO cranial view. And then now you see a really steep RAO caudal view just to see where this tap is. And you can see now here, we go back to an LAO view. You can see the tap here now. We just rotate the catheter gently, and you can see it actually frees up now on the last panel from the actual delivery catheter. And so here's how it looks. We go into more LAO view, and you can see it's separated. So do not pull before you can see that the delivery catheter and the spindle where the tap is actually released from the tap. And you can see that here the nose cone is also centered with the stiff wire pull back so you don't end up the nose cone on release drag the valve out because it interacts with the inflow of the flame causing the pop out. So this is very important. So lately we've actually deployed and delivered the flex nav system with the flush port at 6 o'clock rather than 12 o'clock based on manufacturer recommendation. So we basically flipped the catheter upside down, and we found that when you release the valve because it's upside down, the tabs actually more easily release. You can see that here the 3 tabs simultaneously released. So there's no need to rotate and the C-arm and also rotate the catheter to release the valve. So it's not perfect, but certainly we've seen that this is easier than if the flush port was at 12 o'clock. So I encourage you to give it a shot to try it by having the catheter upside down. Now, what about commercial alignment? So right now, the delivery system and the valve itself is not designed for active commercial alignment, and there's been no consistent technique to achieve that. And you can see that here, out of these 8 sample cases, only 2 are almost aligned on the cusp overlap view. However, cornea access, as you saw, is not a problem even with commercial misalignment. So the vision marker has been perhaps a alignment in the future because it might help pre-orient the valve in the descending aorta to track across the arch and to determine if the marker orientation is preserved. So we don't really know what the predefined flush port orientation is. All we know is that in the LAO view, you want 1 vision marker should be at the inner curve with 2 on the outer curve. And you hope that as it tracks across the arch of the annulus, that relationship is preserved. And at the cusp overlap view, you do want to look for 1 vision marker at the inner curve at the annular contact. This is not dissimilar to what we would expect to see with the Evolut platform. So here's one example. You can see the vision marker. One of them is at the inner curve. And remember, this delivery system is very flexible. So we don't know how to actively control the crossing to the annulus and whether this is preserved. And you can see that when we rotate the C-arm to the cusp overlap view, in this particular case, the relationship was indeed preserved. And you can see there was only 1 vision markers at the inner curve during the cusp overlap view during deployment. And so you can see now very clearly that's 1 marker on the right side of the screen in the cusp overlap view. And then upon release, you can also see that there's only 1 marker with the 1 commercial tab at the right side of the screen at the inner curve at the cusp overlap view as well. So that suggests that good commercial alignment. So overall, the Navitor Vision deployment can be simplified with a single operator. We believe that we can do delivery catheter cross the annulus deeper, then pull back slightly to helmet center first. No need to push or pull the stiff wire during the initial deployment, and no need for pacing. We start with the vision markers just above or at the annulus at the cusp overlap view. We aim to make the annular contact with 2 of the 3 vision markers at or below the annulus. In the LAO frame alignment view, with the parallax removed, and you can even overlap the diamonds of the Navitor frame, you check the LCC depth, and if it's okay, less than deeper than 0 millimeter depth, you can release the valve. Make sure you pull the wire back to the nose cone. The operator does not need to push and pull the delivery system, and you may want to control pacing during release just to make sure you don't have extra systoles. With the delivery catheter flush port at 6 o'clock, instead of 12, when inserted in the femoral artery, we found that the tab release, especially the 3rd tab, is easier than if it's at 12 o'clock. So on that note, I'd like to thank you very much for your attention, and thank you for listening.